All right. Well, good morning, everyone. Thank you for the chance to speak to the broader community about what I'm working on, and this will be generally what I'm working on, and which comprises what I'm working on with the Delaware IMBRI as well. So, what I'm focused on studying is the impact of sex and microglia remodeling within neonatal hypoxic ischemic brain injury. And I am new faculty at Nemours Children's Health within the last 2 years. I'm in pediatric neurology and also appointed at Thomas Jefferson University, Sidney Kimmel, and University of Delaware. All right. And so, introducing the topic of hypoxic ischemic encephalopathy, which is the clinical problem that I'm applying this to. It's relatively common, so it occurs in about 1.5 per 1,000 births, exclusively at term based on its definition. It's a leading cause of cerebral palsy within children born at term. Interestingly, there seems to be actually worse outcomes in boys, at least in humans, and some emerging data that demonstrates that's also true in animal models of this disease. So boys tend to have worse cognitive outcomes, worse motor outcomes. They have an increased risk of vision loss or blindness as a result, and they also have increased risk of hearing loss when compared to girls. So one other topic that I'll introduce is that hypoxic ischemic injuries within the brain of neonates tend to have a couple of different patterns, and those are either a deep gray injury, so a basal ganglia or a thalamic injury, sometimes extending down into the pons as well. And then also this parasagittal or watershed injury can occur commonly. And sometimes that just looks like patchy injuries within the white matter alone. But those are the two most common patterns of injury within term infants who have hypoxic ischemic brain injuries at birth. Then why microglia? So microglia are a critical cell that is necessary for remodeling after a brain injury. And beyond that, they're also important modulators of brain patterning during development, both prenatally and postnatally. So microglia have a lot of functions, and so some of those at least are outlined within this image on the screen. So one important function is that microglia are phagocytic cells, and so they will consume and dispose of dead or dying cells, which in the case after an injury, hitting the white matter, hitting the nuclei, hitting the neuronal cells within the early brain, that can include neurons. That can also include early progenitor cells that may have undergone an injury. And so those cells are then disposed of by the microglia. They can also induce cell death, particularly within neurons, based upon various signals that are present within the brain. They also aid in regeneration and synaptic pruning, neurite formation, synaptogenesis, and so they're important for the modeling of the brain as development proceeds or as the injury is remodeled. And they're also important for the differentiation of neural progenitor cells and oligodendrocyte progenitor cells, as well as their growth. So there have been many studies showing that there are sex-dependent brain differences that are specific to microglia, whether it's due to, whether it's showing that there are more cells in particular locations or different functions of those cells in different locations. And it seems to be hormone responsive. And so early in embryonic development, microglia don't seem to have any sort of differential functions between males and females. But around the time of birth, immediately before and soon after birth, there's a testosterone surge that happens in males. And the microglia respond to that testosterone surge by producing prostaglandins. And those prostaglandins then influence patterning within the hippocampus and multiple other brain locations. And then inferred from that is that there are differential morphologies that then influence the number of cells present in different brain locations. And so what's demonstrated here is an example of some of the differential functions that occur between males and females, males being the blue-purple color and females being the pink color, demonstrating the differences that have been demonstrated between male and female microglia density and presumed function. And interestingly enough, some of these functions of microglia are preserved even if transplanted from a female animal into a male animal, and seem to confer that specified sex-dependent function based upon early life patterning of those microglia, and it's preserved despite being transplanted later into a male brain. And so some of those functions are demonstrated here on the slide. So perinatally, on the left side of this diagram, demonstrates that prostaglandin increase from microglia. That's the response to the testosterone. Male microglia tend to have a more activated form. Within the juvenile life, so neonatally to adolescence, female microglia appear to have more phagocytosis, or devouring of cells, and they seem to target the neural progenitor cells at a higher rate than males. So they have a differential function throughout early to adolescence. And then in adulthood, female microglia are hormone responsive, so they're responsive to estrogen signaling via the estrogen beta 2 receptor, and they appear hyperramified. And so there's assumptions that they have a differential function based upon their morphology differences. However, male microglia seem to be more responsive to inflammatory activation. So taking this a step back, looking at how we can model this injury in a murine model, so in mice. There exists the gold standard model at this time, which is the Rice-Vanucci model. And so this model of hypoxic ischemic encephalopathy utilizes a unilateral carotid artery ligation, so closing off that carotid artery on one side, typically the right, and then subjecting the mice to this prolonged moderate hypoxia. So putting the mice in a chamber, giving them 8 to 10% oxygen, whereas normal is 21%, for about an hour. So prolonged period of low oxygen, which may or may not be typical for what's actually occurring during the in utero period, where they're transitioning from maternal and placental sources of oxygen and nutrients to their own oxygen and nutrients at the time of birth, where they are required to use their lungs to acquire their own oxygen. So this model, it requires a lot. So it requires a survival surgery, expertise in finding the carotid artery and appropriately ligating it without complications. They're subjected to anesthesia, and they have some period of recovery. Then when you subject them to this hypoxia, what you get is a more hemispheric stroke-like injury. And so you're actually taking out a large area of brain on one side, rather than this diffuse injury or patchy injury hitting the basal ganglia, or the watershed injury to the white matter or the cortex. So it doesn't really model what we're seeing in humans, both pathologically as well as it's not modeling the broad spectrum of causes of hypoxic ischemic injury in humans. So what I'm proposing is to develop a more clinically relevant model to what kind of injury we're having in humans. And to do this, I'm proposing to use lipopolysaccharide to induce a maternal immune response during late gestation. So I'm doing that by injecting LPS to pregnant dams at about E18, 18.5. So about a day before they would typically be delivered. And the reason for that is to try to induce an immune response through the placenta, so a maternal immune response that then transmits to the pups via the placenta, because the placenta is integrally important to what's happening in humans at the time of birth. Interestingly enough, a large number of deliveries that are impacted by hypoxic ischemic encephalopathy actually have some degree of inflammation present at the time of delivery, whether it's maternal fever, maternal chorioamnionitis, or sepsis within the neonate, presumably arising at the time of delivery. And then exposing those mice postnatally in order to target the late preterm to term time point in terms of maturation of the mouse brain, which, as it turns out, is actually postnatally. Somewhere between P2 and P7 is what we're currently working with in order to try to model that injury that we're seeing in humans. And so this exposure to hypoxia is a lot more severe than what's used in the Rice-Fanucci model in order to really impact the mice in a way that will produce a severe enough brain injury. So in this case, I'm using 0% oxygen for a period of about 8 to 12 minutes, which the way that it impacts the mice is that they essentially undergo cardiac arrest for some period of time, and then putting them immediately back into 21% oxygen or normoxia in order to allow them to spontaneously start breathing again and the heart spontaneously starts beating again in the majority of cases. And then how I'm going to evaluate this model to see whether it's effective and reproduces the human pathology is one, looking at survival. So are we, able to acquire enough number of mice as the outcome for this injury as one step. And I'll tell you that this is currently what we're working on, is balancing survival from both the LPS exposure prenatally as well as the hypoxic insult postnatally. And there's a clear difference in survival between the early injury versus the late injury, where approaching P7 and at P7, we have a much greater impact on survival from that insult, whereas early life, they seem much more resistant to the hypoxia. And then taking those brains and looking at the histology, so looking at neuronal cell loss with TUJ1, NUN, or MAP2, currently looking at TUJ1, looking for gliosis with GFAP, looking for microglia density, and the density of those cells within identified lesions within the brain using IBA1, and also looking at the overall brain volume changes. So is there a lesion that we can find that reduces the brain volume, whether it's early, middle, or late after injury? So P7 would be within a few days of the injury or even on the same day of the injury. P14 looking a couple weeks out, and then 8 weeks old looking at sort of those early juvenile mice. I'm also looking at motor assessments and early life, so P7, P14, and 8 weeks out, and obviously those motor assessments will change over time. So early in life, P7 to P14, those are looking at limb splay, migrating towards their bedding, moving across spontaneous locomotor activity, and then approaching 8 weeks, looking more at rotor-rot assessments and gait analysis, looking for any obvious signs of motor asymmetries or poor coordination that might identify something similar to what we would see in human cerebral palsy. And then looking later at microglia gene expression changes and subpopulation analysis. The reason for that is because there's emerging theories about how microglia may be actually patterned by the environment with which they are exposed sequentially throughout their existence. So the impact of sex and the patterning that exists within that testosterone surge versus estrogen exposure, intrauterine exposures like the LPS exposure, any underlying genetic mutations, which will be obviously later studies, later directions for this research. And then the impact of age or other systemic factors that may occur and how those may change subpopulations of microglia and then impact brain disease and pathology. So that's sort of the grand overview of what I'm studying. I did want to thank Nemours and the Delaware Embry for funding these studies and open up for any questions that anyone might have or any comments.